This is the second presentation using multi-detector or multi-slice CT in chest and abdominal trauma. It's number 2, prepared by Prof. Sharaf and revised by Prof. Yusriya Sabri. Splenic injury. We have 3 main grades according to the size of injury, either less than 1 centimeter, 1 to 3 centimeter, or more than 3 centimeter, grade 1 to 3, involving subcapsular hematoma or laceration of the spleen. Then if there is cut in the spleen and or extravasation, we have 4A and 4B. If there is intraperitoneal bleeding, it is 4B. If there is no intraperitoneal bleeding, it is 4A. In this slide, we can see that the density of the fluid here is more than that of the density there, and that there is laceration of the spleen more than 3 centimeter, with fluid pouring blood into the peritoneum. The density here is higher than the density there, so this point to that this organ is the one bleeding, and that's why the name sentinel clot. So the word sentinel clot is meant by the bleeding or the clot near to the organ involved. It points to the organ involved. Active intrasplenic bleeding with intraperitoneal, of course, bleeding, denser on the left than on the right. Pseudoaneurysm of the aorta with multiple splenic infarcts. Extravasated venous blood is not moving, so it appears more dense. It's not flowing. So if there is extravasated venous blood, it usually appears as dense, not flowing, persistent. But if it is arterial, it is flowing blood. There is definite active bleeding seen here, there, and here, with shattered spleen and intraperitoneal bleeding. This is reconstruction coronal. Don't forget that there are air distributed underneath the skin, denoting surgical emphysema. Liver injury is more common in blunt, is both common in blunt and penetrating trauma. We should search for visceral lesion collections or active bleeding. That means we are checking parenchyma, its margins, for laceration or hematoma. The visceral lesions means check the parenchyma and its margin for any laceration, then check the presence of collection or active bleeding. Remember that we are using contrast all the time. Active venous extravasation is usually not detected. Thus, evaluate the right paracolic gutter for small amount of fluid. If liver lacerations extend around the inferior vena cava or into the porta hepatis, please suggest avulsion of the right hepatic vein from the inferior vena cava, and in this condition, when the liver is elevated at operation, the tamponade effect of the parenchyma against the bleeding site is removed and massive bleeding occurs. So the key point is the presence of small amount of fluid at the right paracolic gutter, or if the liver laceration extends around or near to the inferior vena cava or into the porta hepatis. This is a very large subcapsular hematoma with active bleeding. And here we have very big liver laceration, different types. And here also there is liver laceration in coronal reconstruction and axial. Mind you that the classification of liver laceration is similar to that of splenic lacerations. Less than 1, 1 to 3, more than 3, with intraperitoneal bleeding, without intraperitoneal bleeding. But the most important point is this one, where the blood is reaching, or the laceration is reaching to the porta hepatis or reaching to the inferior vena cava, or there is small amount of fluid at this region, at the right paracolic gutter. Please suggest that there is a avulsed right hepatic vein, because this will help the surgeon during operation to prevent extensive bleeding when he elevates the liver due to the tamponade effect of the parenchyma against the bleeding site. Now the pancreas. The initial CT may fail to show pancreatic injury unless a laceration within the pancreas is large enough or there is peripancreatic bleeding. That means retroperitoneal bleeding. Always look for fluid density between the pancreas and the splenic vein, normally only fat. If fluid is there, then it is either traumatic pancreatitis or actual bleeding on the posterior pancreatic surface. So the key point here is the presence of fluid behind the pancreas, because this area is normally occupied by fat. Pancreatic injuries often occur where the pancreas is sheared against the side of the vertebral body. So if you imagine that the vertebral body is high up in the abdomen and the spleen is and the pancreas is stretched over across the vertebra, so pancreatic injuries can be explained by shearing effect. The severity of a pancreatic injury is dependent upon the status of the main pancreatic. If it is involved, this may require surgery. Usually requires surgery. Here there is retroperitoneal hematoma, fluid behind the pancreas, and here there is pancreatic laceration opposite the region of the vertebra. And imagine that this region is dangerous because the celiac, superior-mesenteric or inferior-mesenteric could be involved, as they are the anterior branching of the aorta. Here is another shearing injury of the pancreas. Now the hypotension, how to detect hypotension in CT of trauma. Hypotension means shock. Shock is identified as the inferior vena cava being slit-like or flat on at least 3 slices in the infrahepatic segment. And if you find small spleen, this is additional finding. So this is the region of the inferior vena cava in the infrahepatic segment, appearing as slit-like inferior vena cava below the liver. Slit-like inferior vena cava below the liver. And the spleen is small. This is hypotension. Bowel injury. Small bowel injury were twice as frequent as colonic injury. Small bowel is more than colonic. Small bowel injuries consist of perforation or mesenteric avulsion. Colonic injuries are usually serosal tears. theory. As we said before, because the mesenteric vessels, superior, inferior, and celiac are all in the middle, so the small bowel is usually due to avulsion of this mesentery. A group of matted together. Matted together means bowels are arranged together and the spaces in between is obliterated due to blood. This is called matted together loops. Matted together loops. We can see V-shaped triangular opacities, that is blood limited by the root of the mesentery. We can see bowel wall thickening, extraluminal contrast, free intraperitoneal air, and don't forget that we can see shock bowel, but shock bowel also appears dense, and it is dangerous, but it is reversible. It should be followed till it reverses, or it is for surgery. Non-traumatic physiologic fluid collection in the female is seen in the pelvis no more than 3 slices. Fluid location is also extremely helpful. Serous fluid is seen usually away from the bleeding site. Serous fluid, not blood. Remember the sentinel clot. Sentinel clot means blood near to the organ involved, but serous fluid means it is away from bleeding site. So this is called non-traumatic physiologic fluid collection. In the female, normally you can find it in 3 consequent slices, and it is usually serous. Free intraperitoneal blood, it forms triangular opacities like this, like that, and like this. Triangular opacities due to blood trapped by the root of the mesentery. Now this is pneumoperitoneum. You remember that we said about doing neck, chest, abdomen, and pelvis, and we check all in lung window from top to bottom, and then check soft tissues from bottom to top, and then check the bone window. So while checking the lung window, you will find the pneumoperitoneum and pneumodiastinum and any air collection. Free intraperitoneal air can be inside the peritoneum, can be outside the peritoneum. Here it is some appearance of matted together loops. Thank you.